Hi, it's Pauliano here, Principal Dentist from Tangmere Dental Centre near Chichester. In this video, I've put together the results of a lot of previous videos that I've made. I'll put links to these in the description below. This is where I measure the settling times using vape-smoke, as this is a visible and easily reproducible aerosol. I've trawled through the data and I've made some graphs, so you can easily compare the relative effectiveness of simple air ventilation and then engineering control methods of aerosol control. I'll remind you though that these are part of my own personal risk assessments within my own dental practice, and as such you should only use them for guidance. I'll also remind you that vape smoke actually isn't the same as aerosols generated by dental equipment. I've demonstrated in some earlier videos real dental aerosols can take much longer to settle. So anyway, back to the tests and back to the results. Susie, my wife, uses a non-nicotine vape to blow 5 breaths to max out the particulate meter, so this can be a really good test of settling or clearing times. The mitigations that I've tested so far are an open window, 6 room change per hour air extraction system, an air purifier, the Winix Zero Pro in my case. I've also tested 3 different makes of LEV. These LEVs are the DentalAIR by Vodex UK, the DentalAIR Aerosol Pro made by BOFA, and the VacStation from UK Dentistry. Take a look at this little clip here where the aerosol hits the aeroshield on the DentalAIR, and even though some escapes, most actually curls back and is captured. I think that this will prove to be the safest way to work in dentistry routinely behind a shield like this, as any bugs from a person's breath are being captured, killed and binned in the air filtration units and the purification systems. I'll produce a video shortly to show the usability of my favourite LEV, the DentalAIR, and with reference to the competing units, I'll point out the faults and limitations of each. Anyway, first the baseline test graph. In this graph, you'll see that all the particulates that the meter can read is PM1, PM2.5 and PM10. These meters are really sensitive, and the PM1 reading is actually very fine dust. And yes, aerosol or liquid droplets are measured and are included as particulates. The point is though, that in this graph you can see all the particulates track a very similar line in terms of them settling. In fact, contrary to what you would think, it's actually the larger particulates that consistently take longer to settle. As it's the larger particulates, PM10, that is considered to be potentially carrying enough viral load to infect another person, and it actually takes longer to settle, it was decided to use this value as a reference when comparing methods. To get these readings, it was found that 5 breaths of vape smoke blown straight up into the air without any mitigation maxed out the meter, so this was used to try and be consistent and test any mitigation or recommendations that we've been advised. Fine, okay, let's start the timer. For all of these, it was ensured that all the readings were below 10 on the PM10. This level was arrived at as earlier tests in the room had revealed that first thing in the morning, particulates were around about that level when the room had been left unused for several hours. As you can see, it took about 13 minutes for the aerosols to settle down to a PM10 value of below 10. Levels dropped quite quickly at first, but then levelled off and settled very slowly back to normal. Right, on to the second test and the first of the mitigation measures, simply opening the window. I'll point out this test was done in the summer, which was fine, but now it's winter, it's not so practical. This one, in fact, was one of the early recommendations, simply open a window, if you're actually fortunate enough to have a window. So the idea is to allow ventilation of fresh air in and so dilute the aerosol and so reduce the risk. As I said, I did this test in the summer on a relatively breezy day, but it wasn't too windy, and I suppose this in itself is a variable. If we take a look at the graph, you can see that earlier on there was quite a big dip downwards back towards the standard of PM10. Then it went back up and basically bobbed up and down a little bit. I did move around in the room to simulate normal working to see if the aerosol levels at the meter would change if the air was disturbed. But look at the graph. Compared to the baseline, whilst there is some effect, it really isn't significant enough to be relied upon to reduce fallow times. And we do live in the UK after all, and everyone knows that our weather is less than predictable, so there's no way you could actually pre-book an appointment assuming there's going to be a breeze on the day, and so you'd be able to say the aerosol has actually been blown away. What's really needed is something consistent. It's clear that simply opening a window, whilst it helps, is not really the solution. So how about extraction of air from the room, replacing it with clean air? This was the second mitigation method and is still now the recommended way to reduce fallow times here in the UK. Maybe after watching this and possibly doing some simple tests as I have done, recommendations may actually have to change. I'll let you actually make your own mind up about that one. Fortunately, the system I have does bring fresh air in from outside. It is a brilliant but very complex system. It has an absolute massive ducting going through the roof space. With the outgoing air going through a heat exchanger and filters though, it does mean that this is clean air from the outside that's preheated, and I know where it comes from, and it shouldn't massively increase my heating bills. Anyway, let's take a look at the results. If we look at the graph, the vape-smoke aerosol clearing time, you can see there's not a great improvement over the baseline, and that's for this air extraction. If you remember the readings from real dental procedures, the aerosol almost refuses to settle, and it's actually still detectable in the air for almost an hour later. Indeed, if you're actually relying on this method to be safe, it could actually increase the risk, as it encourages the doffing of PPE before that air could actually be safe to breathe. Therefore, it's my conclusion, 6 room changes are obviously not enough. And I think someone else did a test as the UK recommendations were increased from 6 room changes to 10 to 12 room changes per hour. Personally, I do not believe that to get an extractor to suck harder for greater airflow is the answer, unless it's almost hurricane force or somehow it's possible to get multiple points of extraction in a room. I think it's a fatal flaw with air extraction. Being a single point of extraction, the air simply flows following the path of least resistance, and in doing so, more dangerously leave dead zones of undisturbed air where aerosol settling could take much longer. There has to be another solution, I think. LEVs are in fact specifically mentioned, and if you look at the hierarchy of control for airborne contamination in industry, the effective answer has always been there. Engineering methods come right near the top, and I suppose this is where the advice for air extraction has come from, but LEVs are specifically mentioned and feature in the Health and Safety Executive's HSE guidance on control of hazardous substances to health, COSH. It's document HSG 258-2017, which I'll copy in a link below. I find it interesting that a simple, easy to implement mitigation like an LEV does not feature in our recommendations or our standard operating procedures here in the UK at present. I do hope that someone with influence is watching and can see the sense of local extraction. Anyway, in my surgery I've had the luxury of being able to test open windows, air extraction and also 3 different makes of LEV now. Comparing the VacStation and the DentalAIR and the DentalAIR Aerosol Pro. Firstly, looking at the VacStation, the readings are maxed out on forced breaths, but readings return to normal levels in only about 90 seconds. With normal breaths, they generated some readings, and these went up to 81 at PM10 and fell in about 48 seconds. The DentalAIR Aerosol Pro also maxed out the meter but fell quickly to normal within 44 seconds. Normal breaths also gave a reading but fell slightly quicker in 21 seconds. The DentalAIR gave the lowest peak readings when actually trying to make it fail, and that was the only one that actually didn't max out the meter. Forced breaths with the DentalAIR settled in 96 seconds. Also, the DentalAIR is the only unit where readings actually fell during normal breaths of vape smoke, so meaning that there was no detectable escape of contaminant. I think it's fairly obvious that this is largely down to the aeroshield on the DentalAIR. Remember the clip where I test real aerosol from an airflow GBT machine that actually produces the most aerosol of all. It hits the clear plastic visor and actually curls round and then is drawn back into the suction head. And so it doesn't significantly envelope the clinician who is operating just the other side of the screen. In this real aerosol test, the reading fell within minutes, and so almost eliminates fallow time. I truly believe that the DentalAIR, with its clear aeroshield to work through routinely, even during non-AGP procedures, will reduce our risks almost back to normal, or shall we say a new normal with higher level PPE, but of course without the need of hugely extended appointments for fallow time, just a little bit extra for that continued deep clean between AGP patients. Right then, the final bit of equipment, as I promised you, a little bit of a dark horse, as it yielded a really surprising result that I didn't expect. And I think in combination with the DentalAIR, this should be regarded as the dream team for aerosol mitigation. This is an air filtration and purification unit. In my case, I'm using the Winix Zero Pro, as together both units can be obtained for under £2,000 per surgery. And of course this can be very rapidly paid for by the reduction in fallow times, but more important, it's actually safer for everyone, especially me. As I said, I wasn't really expecting the results to be as good, but take a look at the graph. The particulates did max out during the vape-smoke test, but returned to normal surprisingly quickly, only 133 seconds, that's 2 minutes 13 seconds. And this was such a good result that I repeated it several times to find out that the results were reproducible. This is not actually far off the settling time for the LEVs, and it's substantially better than extraction or an open window dilution methods, and of course doesn't suffer from the disadvantage of pumping all that heated air outside. I couldn't really explain why this occurs, and I've yet to get a scientifically backed reason. Personally, I've added the DentalAIR and the Winix Zero Pro to all of my surgeries, and I now use them in combination. I use them routinely for both AGPs and non-AGPs. The DentalAIR is just so practical and usable. With the shield, I feel so safe. It even protects you from, well, garlic or curry breath, let alone COVID. I do intend to make another comparison video of these LEVs in terms of the practicality and so forth, just as a quick summary. Let me know if you find it useful. Anyway, thank you for watching. If you found this useful, give me a thumbs up and look in the description for the actual tests that I've done. If you're interested, I do encourage you to carry out your own risk assessments. Also, take a look at my real dental procedure aerosol video. I'll link this afterwards or up here. With the DentalAIR and the Winix Zero Pro, dental aerosol settled within a minute on several tests. If you're interested in seeing any of my other content as soon as I produce it, please consider subscribing and hitting the notification bell. And yes, thank you very much. Stay safe, take care, and see you next time.